So HIV stands for Human Immunodeficiency Virus. It's a retrovirus and contains RNA, not DNA. That's important when we talk about treatment, so we'll get to that in a second. HIV primarily infects the CD4 T cells of the immune system, and that's where it replicates. But a virus needs DNA to replicate, which HIV doesn't have. So it produces an enzyme called reverse transcriptase, which uses the RNA as a template to make DNA. Once the DNA has been produced, it's integrated into the nucleus of the host cells, and the host cell then begins replicating the virus. Knowing how HIV replicates is important, because right there is a big part of how we treat it. We use drugs called antiretrovirals to treat HIV. There are several classes of ARVs, and the two most often used classes relate to the reverse transcriptase enzyme. Okay, so the first of these classes is the nucleoside reverse transcriptase inhibitors, Nrtis, and these drugs act like the nucleotides used to build DNA. So when reverse transcriptase tries to build viral DNA using the nucleotides available in the cell, the Nrtis mimic the nucleotides and act like defective building blocks. That prevents any further nucleotides from being added to the DNA chain. So they actually block the building of new DNA molecules by sitting on the chain, and this inhibits the ability of HIV to replicate. Nrtis are considered the backbone of our first-line treatment of HIV, and we'll talk more about that in a minute or two. Now, the second class is the non-nucleoside reverse transcriptase inhibitors, or Nnrtis. These drugs also inhibit the action of reverse transcriptase, but they don't do it in the same way as the Nrtis. Now, the Nnrtis bind directly to the reverse transcriptase enzyme, therefore prevent the enzyme from attaching to the viral RNA at all, and prevent it from doing any production of viral DNA. Okay, that's it for the drugs that affect reverse transcriptase. Now we'll get to the other classes of drugs, and there are three classes of ARV that don't affect reverse transcriptase. First of these is fusion inhibitors. Now these drugs bind to the CCR5 receptor on CD4 cells. This is where infected dendritic cells bind in order to fuse with CD4 cells, and that's how HIV enters the CD4 cells. Now, by blocking the CCR5 receptor, the fusion inhibitors prevent HIV from entering into the CD4 cells because they prevent the dendritic cells binding to the CD4 cells. Therefore, they prevent infection of the CD4 cells. However, fusion inhibitors don't actually work in all patients, and so they're not used in first-line treatment. Now, the second class is integrase inhibitors. Now, the enzyme integrase connects viral DNA to host DNA. So by binding to integrase inhibitors prevent it from connecting the two types of DNA. So they prevent the viral DNA from being integrated into the host cell, and therefore prevent the host cell from replicating viral DNA. Now, as of 2020, integrase inhibitors are part of first-line treatment, and we'll talk more about that when we get to the actual drugs we use. Now, protease inhibitors are the third type. Now, in order to create new viruses, HIV needs peptides. It uses proteases to break down cellular polyproteins to smaller molecules, then uses these smaller molecules to assemble new viruses. Now, by interfering with breakdown of polypeptides, protease inhibitors prevent HIV from having material to assemble new viruses, and therefore decrease its ability to infect new cells. Now, there's one more class of drugs used in HIV treatment, but they don't actually interfere with the virus at all. They're called booster drugs, and they only apply to protease inhibitors. What these drugs do is they boost the effectiveness of protease inhibitors by preventing metabolism of the drug by the liver. So by preventing metabolism, the drug circulates longer, and the effect of the drug is then increased. Okay, so now that we know what drugs are used to treat HIV, let's get into the treatment principles and the principles behind what we treat with. And the big principle for HIV is mutation. Now, HIV replicates really fast, but it also has a high error rate in that replication, which leads to a lot of mutation due to the errors. And with mutation comes resistance, and we don't really want HIV to become resistant to the drugs we're using because ARVs are so important. So what we do is we use a multi-drug combo, and we treat with multiple drugs at the same time. And so the underlying phrase that we use to justify the multi-drug treatment is to try and use the mutations to our advantage. We try and take what we know and use it to our advantage. And the phrase you need to remember is this. We use specific drug combos to use HIV's predictable resistance patterns to our advantage. And I'm going to repeat that because the first time I heard it, I didn't get it either. Right? So we use specific drug combos to take advantage of HIV's predictable resistance patterns. And yeah, we use that to help our treatment. Basically, we know how HIV reacts to certain drugs and what the reaction is to the multi-drug combos. So we tailor our combos to get the best results out of HIV's documented and well-known patterns. And we try and use that to best influence our treatment of the virus. So we're using what we know about the mutation patterns to create a virus that's actually easier for us to treat. And that's what we're aiming for. So we've reached the part that you'll actually need to know when prescribing drugs and treating your patients. Well, what you needed to know before this was why we do that, but now you'll need to know what to do if your patient needs treatment. So for those of you who don't know, in 2019 there was an update made to the ARV guidelines, and since that time, I think it was October last year, we've been using a new first-line treatment. And the treatment I'm talking about in this video is the treatment as of 2019-2020. So our first-line treatment is actually one pill that your patient can take once a day, but it contains 3 drugs. And this one pill we call a fixed dose combination. So it contains a fixed dose of 3 different drugs, so your patient can take it more easily, because we want to reduce the burden of actually taking 3 drugs and taking them how many times a day. Yeah, so the 3 drugs contained in this FDC, fixed drug combination, are drug 1, being the Nrti, is tenofovir. Drug 2, which is your crippler, is lamivudine. And drug 3 is dolutegravir. Now, this is a bit of a different drug regimen than we were using before. Drug 3, dolutegravir, is new. We didn't use it as first line before. It was still in our treatment, but we never used it as first line. So dolutegravir we need to actually talk about for a minute because it's the important drug to know when prescribing first line treatment now. So it's an integrase inhibitor, and the important thing about dolutegravir is its side effect profile. Overall, it causes very few side effects relative to other ARVs, and that's important because when you speak to patients who are HIV positive, and if you speak to, medical students, colleagues, anything, who have had a needle stick, who are HIV positive, or who have had a splash injury and have taken prophylaxis, they'll tell you ARV side effects can be debilitating. They can be really horrible. So it's important that dolutegravir causes very mild side effects and infrequently. But there's one side effect that we really need to talk about, and you need to know before you prescribe it. And that side effect is neural tube defects. So dolutegravir has a chance of causing neural tube defects, which is slightly higher. It's a slightly higher risk than some of the other drugs we use as our ARVs. So what you need to consider is if you have a patient who is less than 6 weeks pregnant or is considering becoming pregnant in the near future, don't recommend dolutegravir, right? This TLD regimen, so tenofovir, lamivudine, dolutegravir, is probably not the one you should recommend there. Right? So for these patients, any patient who is less than 6 weeks pregnant or who wants to become pregnant in the near future, we recommend an alternative regimen. And it's actually the regimen that we were using as first line before the update. So again, drug 1, Nrti, is tenofovir. Drug 2 is an Nrti, and it's emtricitabine. And drug 3 is efavirenz instead of dolutegravir. Now, the benefit of this is that it also comes in a fixed drug combination because it was our previous fixed drug combination. So again, it's easy for patients to take. It's one pill a day, and it's got less risk to patients who might become pregnant or who are less than 6 weeks pregnant. But if your patient is more than 6 weeks pregnant, the official government guidelines say you can recommend that they take the first line treatment, which is tenofovir, lamivudine, dolutegravir. And there's no risk there because after 6 weeks, your neural tube is already formed. So taking dolutegravir then won't influence the neural tube. It won't do anything to cause a neural tube defect. So any patient that is more than 6 weeks pregnant and has no plans to become pregnant in the near future, you can recommend dolutegravir. But remember to have a conversation with them about contraception, because it's important then that while they're taking dolutegravir, that they're on some sort of contraception. Ask your patient what's most comfortable for them and then try to get that for them if you can. And in terms of patients who are less than 6 weeks pregnant or want to become pregnant, you recommend the alternative regimen, which is tenofovir, emtricitabine, and efavirenz. But, and I'm quoting from government guidelines here, you can recommend that they take either of these two depending on the situation, but ultimately it is your patient's choice. Once you've explained the risks to them, once they know what's going on, they must decide which treatment regimen they want to take. And I mean, that makes sense. They've understood the risks, they know what they're doing, and you have to respect that decision. Okay, so we've come to the end of the video. We've covered everything from HIV's replication to the drug classes, to why we use these drugs, and to what the actual treatment plans are and what you need to consider. If you liked the video, please leave a like and comment. Don't forget to subscribe to the channel and consider supporting the channel on Patreon. We do have our next series coming up after this, which is going to be a series on interpreting ECGs, because I've gotten a few requests for that. So make sure you turn the notification on so you don't miss the ECG series. Thanks everyone for watching, and I'll see you again next time.